دكتور
لايف الحمد لله.
يلا.
ممكن تبدأ.
دكتور حنبدأ دحين. يلا.
أنا جاهز يا باشا.
جاهز دكتور؟
أنا جاهز.
صوتك بعيد يا دكتور. لا 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 لا. Don't share please. Don't share.
طيب.
Don't share please. Stop sharing. طيب. بسم الله والصلاة والسلام على رسول الله وعلى آله وصحبه ومن والاه. Dear our eminent speakers from Egypt, dear our stars speakers from SGH Medina, dear our attendees, welcome to our pediatric webinar titled Children in and After COVID-19 Lockdown. Allow me to introduce our moderator today. He's a professor in pediatric, Professor Dr. Nabil. Professor Dr. Nabil. تفضل دكتور نبيل.
بسم الله الرحمن الرحيم. والصلاة والسلام على أشرف المرسلين سيدنا محمد صلى الله عليه وسلم. طيب
دكتور unmute please. دكتور unmute. كمبيوتر دكتور أماني unmute.
المهم نبتدي على طول. احنا بنطيب الطيبة.
دكتور unmute please. دكتور صوتك مو طالع. دكتور نبيل. تفضل دكتور.
سامعني كده؟
كده تمام. تفضل دكتور نبيل.
ابتدي؟
تفضل.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه. من طيبة الطيبة ومن داخل المستشفى السعودي الألماني, one of the leader of the healthcare professional in Saudi Arabia and the Middle East. It's our pleasure to represent today the most hot topic of COVID just flying all over the world. And from here, we are going to make a very, very attractive and professional presentation with the show the magnitude of this corona in a very, very practical way. We don't know about corona before, but it have no benchmark to consider. In the same time, in children, it's completely different, as you are going to see with Professor Nader. In the same time, the corona event affected not only the health, but also the economy and the psychological aspect of the children. And their psychological aspect, not only for being locked in, but from the separation of the dearest grandfathers, mother, and the other family. And this restriction was for a long time, but it was very important as a protective way to involve these strategies of the Saudi and international WHO and everyone. From the start, we have our keynote, a very professional leader all over the world, Middle East and Egypt, particularly in Alexandria. My dearest Professor Dr. Nader Fasih is the former head of department of Alexandria University, and one is of the pioneer pulmonologists among Egyptian society and European society. He's one of the two out of the Europe ERS member who is training in bronchoscopy and all signs related to chest in children. In the same time, we are going to have with us Dr. Amir Shankiti, the infection control consultant of Tiba University Hospital in Medina, and he is a Canadian board in infectious disease. The star of the COVID and the corona infectious protection is our dearest doctor infection prevention and control, Dr. Hamza, and he's going to give you a very, very simple but very, very practical lecture as well. Among the extreme of the healthcare problem that chronic cases will have some tuning for their health. We'll take one example from our dearest associate professor, this Dr. Amani Ibrahim, who is going to give a hint about the manipulation and the strategies among children having type 1 diabetes mellitus. At the end of our talk, we're going to have the dessert of the webinar, our dearest Dr. Soha Galal, the pediatric registrar, one of the most famous one in Medina, and also she have post-graduated program of nutrition in children. And now it would be my pleasure to introduce Professor Nader Fasih. Please, sir. Dr. Nader, please.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين. أنا first of all I want to thank the مجموعة المستشفيات السعودي الألماني Saudi German Hospital Group for inviting me for this elegant webinar who discuss children in and after COVID-19 lockdown. And I want specifically to ask my dear brother, Mr. Ala Eddin Ibrahim, and also my dear brother, Professor Dr. Nabil Badran, and also to all the joint speakers, Dr. Amr Shangeti, Dr. Aman Ibrahim, Dr. Hamza Sharafuddin, Dr. Soha Galal, and I hope to be informative talk about childhood COVID-19. Is it different than in adults? This is the main topic today. I will start because I am indulged in the international pulmonologist consensus on COVID-19 with a huge and a big collections of most of the pulmonologists worldwide, from China, from Italy, from Singapore, from we did a consensus, and also we did another update for this consensus in April 2020. The objective of the presentation today, we should give an idea about a preface about COVID-19 infection, then the burden of COVID-19 in children compared to adults, and then why children are less presented with COVID-19 when compared to adults. And the third point is the differences and similarities of symptomatology between children and adults COVID-19. And the last point is the differences in the laboratory and radiological finding in children with COVID-19. First, we start with that we have 3 requirements must be satisfied to ensure an infection with an individual host. First is sufficient virus must be available to initiate infection. This is number 1. And then we get cells that at the site of the infection, which must be accessible, susceptible, and permissive for the virus. And the third point is that the local host antiviral defense system must be even absent or initially infective in order to get this problem. And then if we are discussing these issues, we should know that we have many factors affecting this viral infection. First of all, I'm trying to do something first because yes. First of all, we are in need to do that. We have many factors involved in the viral infection. First is the virulence, which can be quantified by many methods. One of these is the measuring the concentration of the virus that cause death of 50% of the organism, which is known as lethal death, lethal dose 50. Or causing paralysis of 50% of the organism, which is known as paralytic dose 50, infection of 50%, which is known as infective dose 50. We can compare by this way whether we have more virulent or less virulent. The second point is the amount of the inoculum. However, the dose of the infecting virus may be correlated to the kinetic spread of infections and the clinical manifestations. However, this is well evident in one example like rhinoviral infections. The spread of replications. The spread of replications, if we have virus, we so fast way of replications, this means that we have an acute onset of infections, for example, H1N1 viral infections. But in case of SARS-CoV-2, we get the infection manifestations a little bit more delayed. So it means that we are reflecting that the speed of replications is a little bit less fast than H1N1. And then the viral spread, whether we have this viral infection is localized to a specific region like respiratory epithelial cells, for example, spread to other organs like cardiac, like the intestine, like the blood vessels, or something like that. For example, we have in COVID-19, we get also multi-system affections because we have a lot of many other systems that can be affected. Also, example, measles is an example of the viral spread not localized to the site of the infection. Another point, which the host-dependent factors, which is the immune system of the body of the infected personnel, whether this is immune or immune compromised, and whether this immune compromisation may be primary or secondary immune compromisation. And also the nutritional status, because all of us, we know that patients who are underweight or malnourished are more susceptible for infection than patients who have good nutritional status. Also, the age is very important issues because in SARS-CoV-2, we have many issues as regard the age because the disease is associated with more severity, more comorbidities in old age because they have a lot of comorbidities and also a little bit less virulent and less invasive and less complications and less infection in young age. Also the sex, we get that in SARS-CoV-2, we get more affection in male than in female. However, this may be related to some of the hormonal factors or the genotyping of the ACE2 receptors. Also, obesity is one of the comorbid factors which may play a role in the comorbid factors for more severe manifestations. And then the last point is the environmental factors like pollution, like climate, like humidity, like crowdedness. All of these factors are very essential and important for and playing an important role for the spreading of the infection and affection of the severity of manifestations. Our topic today is about coronavirus in particular, which is coronavirus genus of Croniviridae family, including 4 genera. Both Gamma and Delta genera infecting birds mainly, and in some situations we may get infection in mammals. But till now, we have no recorded human coronaviruses affecting human bodies related to the Gamma and Delta genera. And all the coronaviruses which affect human beings are related to the alpha and beta genera, and all alpha and beta genera, they are zoonotic viruses infecting mammals mainly, and they are in need for reservoir animal in order to be transmitted from the mammals to the human being. The oldest coronaviruses, 229A and OC43, are well known since 1960, and the NL63 and HQ1 definitely recently discovered in 2003 and 2004, and we should know that coronaviruses are the most common, are the second most common viruses causing upper respiratory tract infections in all age group. And the development of severe acute respiratory syndrome in 2004 and Middle East respiratory syndrome in the eastern part of Kingdom Saudi Arabia definitely are the start of severe form of coronaviruses. And the last is the SARS-CoV-2 discovered in 2019, definitely is that we are in need for reservoir animals like camel in the Middle East respiratory syndrome, and in COVID-19, we maybe get, till now the reservoir animal is not yet well proved whether it is a pangolin or a civet cat. Sure, we are in need that this virus is a single-stranded RNA virus in which we have many glycoprotein proteins on the envelope, like small envelope glycoproteins, membrane glycoproteins, and what is the most important to us is the spike glycoprotein. This spike glycoprotein is further subdivided into two subunits. The most important one is the S1 subunit because it is the receptor of binding. And the similarities of the S1 domain of the COVID-19, it is more or less very similar to the SARS. And that's why we have the same receptor, which is the angiotensin converting enzyme 2 receptor on the cell wall that is the site of binding of coronavirus. And we should know that at that site, when the coronavirus binds to the ACE2 receptors, we get here endocytosis and inclusion of this ACE2 inside the cell, what is known as internalization. So internalization is a very important issue that cause marked reduction of the ACE2 receptors because most of that linked to the coronavirus are become inside the cell. In a phylogenetic study analysis of 103 strains of SARS-CoV-2 in China, they get two types of SARS-CoV-2. The L1, which is the most common, 70% of cases, and the S1, in which we get 30%. Definitely, till now, we have no data about if there is differences in the clinical manifestation, the severity of manifestations, the incubation periods, the course of the disease in which two types, we don't know any informative data about these issues. But we should know that ACE2 receptors here is the functional receptors for the coronavirus. And as again, we see here that invagination and we get the part of the epithelium, including the ACE2 receptors with the virus, become included inside the cell, which is known as internalization, which cause marked reduction of the ACE2 receptors inside the cell. And another important issue is that SARS-CoV-2 has 10 to 20 more affinity to the ACE2 if compared to the SARS virus. And that's why we reflect another important issue is that why SARS-CoV-2 is more infectious, more contagious than the SARS, because the affinity of the ACE2 receptors is much, much, much higher. Another important issue is that the ACE2 receptors are well expressed in the lung epithelium, in the kidney, in the blood vessels, and in the intestine. And that's why we may get multi-organ affections. And recently, ACE2 receptors are highly expressed also in the mucosa of the oral cavity. But we should know some important data about that, because inside the body, we get an important angiotensin converting enzyme pathway inside the body, because we have a downregulation of the ACE2 receptors, in which we have normally inside the cell a balance between ACE2 and ACE1 enzymes. When we get downregulation of the ACE2 inside the cell, so we get an increase in the ACE1 enzymes with conversion of angiotensin 1 into angiotensin 2. And this angiotensin 2, once increased much, it causes an increase in the type 1A angiotensin 2 receptor, which causes, as we can see here, vasoconstriction, pro-inflammatory response, and the pro-oxidative pathway, and also pro-fibrotic. And this will lead to increase in the pulmonary permeability. Another important issue is that in normal situation, when we have a balance between ACE2 and ACE1, the ACE2 usually causes transformation of excessive angiotensin 2 to angiotensin 1 to 7. And this will lead to vasodilatation, anti-inflammatory effect, antioxidant effect, and anti-fibrotic effect. However, in absence of ACE2 inside the cell, due to its downregulation, so we get stoppage of this way, and so we miss the protective effect of the ACE2 inside the cell. Also, ACE2, as we can see here, has a protective effect against the bradykinin that causes vasodilatation, vascular permeability, and so also due to downregulation of the ACE2, we get a lot of vasodilatation and vascular permeability. The epidemiology of the disease, we can get that usually it is between 1-2 days up to 14 days, with average 5 days. And the patient may be infective during the incubation periods. This is definitely proved. And there is mounting evidence that spread from asymptomatic contact can occur, and also has been observed in endemic areas. And some people can act as super spreader early in the course of their infection. But till now, it is unknown whether perinatal transmission or transmission via breastfeeding are possible or not. And till now, there is currently a lack of data about the risk of transmission to the newborn during vaginal delivery. So the first important question, is the incubation period in children the same as in adults? Definitely, we have shorter, a little bit shorter incubation period in pediatric age. If compared to adults, it takes about 2 to 10 days compared to 14 days in adults. The second important differences between pediatric age and old age is a very important issue, is that the burden of COVID-19 among the children is much, much, much less if compared to adults. We can see here in USA, it ranges between 1.6 to 2% of all affected people occurs in childhood below 18 years of age. And we can get in China, 2.2% of the total number of populations affected are children below the age of 18. In Italy, 1.2% of the total populations affected are below 18 years of age. In Spain, just 0.8% of the total affected people. However, in Egypt, 5% of the total populations affected with COVID-19 are children below the 18 years of age. Why we have a little bit more children affected in Egypt still is much less than the total number of populations affected, but still higher than any other countries, maybe double. This is maybe due to the demographic data that children may represent a higher number of the demographic data in Egypt, which can reflect why we have a higher rate of expression. And also there is another important issue is that most of the affected children, more than 60% of cases are usually 10 years or above. So we get about 60% of the affected children are beyond the 9 years of age, over than 10 years until 17 years of age. So we have the most affected group is the older children, not the younger children. And children below the age of 5, we get just only 25% of the total number of children affected is below the age. So even in young age, the disease prevalence is a little bit much lower, even if compared to the older children. Our question is now, why children are less susceptible to disease, not to infection, because of the following explanations. First of all, that it may be related to the fewer outdoor activities and undertake less international or even regional travel, making them less likely to contact with the virus. This is a very important issue. The second is a more modulated innate immune response. Second is healthier respiratory tract and fewer underlying disorders like comorbid factors, like obesity, like cardiovascular diseases, like diabetes, and etc. Also, there is an important issue that they have not been exposed to much cigarette smoke or air pollution like adults. Another important issue is that children usually are less likely to express their symptoms like shortness of breath, like difficulty breathing, like anosmia, like sore throat. So this may lead to underdiagnosis. So we have an infection in children, but not yet well expressed enough. Also, the cross-exposure with other coronaviruses, which are responsible for the second most important cause for respiratory tract infection in all age groups. So this may cause cross-immunity with coronaviral infections. That's why children, which are more prone for respiratory tract infections than in adults, have more protection. And the last point, which is the recent one, there was an important study before in rats and in mice, not in humans, showing that we have an increased ECE2 expression in young age and decrease with older rats. But nowadays, definitely there are a lot of studies showing that we have definitely an ACE2 expression which increase with age. However, this may explain why ACE2, which are the functional receptor of the SARS-CoV-2, are very low expressed in infants and young children. That's why we have an increasing rate of infections as the child becomes older. And that's why we have a very low affection in young children, and we have more and more increase as the age increase. However, this theory is much more acceptable. And however, we can see here in this graph how disease severity is, if we compare young age with, I'm sorry that the mouse, yes, okay. Yeah. And so definitely we can see here how the severity of manifestation in children are much less if compared to others, and how in late phase of the disease, much more comorbidity occurs with elderly patients if compared to adults, if we compare that to the very young age. Now the period of infectivity, yes, it is different or not. We have many studies comparing the period of infectivity in children than in adults, and we can get that in adults, most of the studies depend on the viral RNA detection, which actually detection of messenger RNA in the respiratory secretions doesn't necessarily indicate the presence of viral infection. And they definitely found that the viral RNA level from the upper respiratory tract infections appear to be higher soon after the manifestations of the symptoms. And the transmission might be more likely, very importantly, early in the severity of the disease. And the second, that the duration of shedding in adult patients is usually, it takes, the average is 20 days, and it range between 8 and 37 days. However, in children, this is a little bit lower with a median duration is 10 days in pediatric age when compared to adults. And 90% of repeated negative viral tests in the nasopharyngeal secretions in adults is usually by day 10. but in children by day 8. So we have a little bit shorter period of duration of viral shedding. And we should know that we may get viral RNA level, but less than 10 raised to the power 6 copies per milliliter, which may give negative results, although that we have a little bit copies. Also the R naught, which is the basic reproductive index in which we have the rate of which reflect the rate of transmission of the disease, which may range between 1 and 5, different from area to area. And also we may get 6% possibility of transmission of the disease in the asymptomatic carrier. As regards the symptomatology of patients of COVID-19, we can get here the blue column reflecting the pediatric age and the orange one reflect the adults. And we have fever may present in 42% in children when compared to 98% of adults. And so fever is present only in half of cases like in adults. And also cough may present in 48% of cases compared to 82% of adults. And so even about half of the cases in pediatric may be affected than adults. Myalgia in 22% of cases in pediatric compared to 56 patients in adults. Shortness of breath in 12% of children compared to 36% of adults. And so we can reflect how much children are less representing than in adults. That's why we may miss some of these diseases and we have a larger number of patients without manifestations. However, in an Egyptian case series pending for publications, we get another important symptomatology. I don't know that in Kingdom Saudi Arabia, like anosmia, which is present in 72% of adults, a very important issue in Egypt. GIT manifestations is present either an earlier manifestation or during the course in more than 52% of patients, sore throat in 56% of patients. Fatigue is a very important issue, and myalgia in more than 85% of cases. Also, the course of disease is usually prolonged more than 12 days in more than half of percent of patients, and 60 and CT scan of the patients may be not correlated to the symptomatology in 42% of patients. The classification of the symptomatology in pediatric age, we can get asymptomatic, in which we have no clinical signs or symptoms, normal X-ray and CT with positive PCR. Mild, we have mild upper respiratory symptoms like cough, fever, sore throat, sneezing, rhinorrhea, myalgia, or some GIT manifestation like diarrhea or vomiting. We have normal pulmonary examination with positive PCR. The moderate case, in addition to the normal upper respiratory manifestations, we get positive pulmonary like crackles and or wheeze, and the typical high resolution CT finding, and the positive PCR testing. The severe cases in which we have, in addition to the above manifestations, we get deterioration of respiratory symptoms with the development of tachypnea, dyspnea, hypoxia, less than 92%. This means usually arising in the 7th or 8th day of presentations. The critical case in which we get signs of shock, respiratory failure, or heart failure, myocardial dysfunction, encephalopathies, cyanosis, organ dysfunctions, or even convulsions. So in the largest group, serious group in China, we get 2,104 3 children suspected cases. And from these suspected and confirmed cases, only 731 are confirmed. And so we get asymptomatic patients was present only in 13% of cases compared to less than 4% of cases for the confirmed cases, and the mild to moderate cases representing about 90% of cases, so asymptomatic mild and moderate representing more than 95% of cases, with the severe and the critical cases are only representing 5.6. severe in only 5% of cases, and the critical cases just 0.6%, which are very few number of cases. There are no specific symptoms in children for COVID-19 that you can justify that we have definitely COVID-19. For the lab investigations in adults, if compared to adults, lymphopenia is only present in 15% of young children compared to adults, which is present in 80% of adults. So we don't rely on the CBC because we have 15% leukocytosis, 28% leukopenia, 40% lymphocytosis, and just 15% lymphopenia. Thrombocytopenia is a bad prognostic marker. CRP is not yet very important. It may be rise or not. Serum ferritin and procalcitonin with elevated LDH, ALT, ACT, renal functions may worsen with the progression of the severity of manifestations. Elevated D-dimer is a bad prognostic criteria. Then we are passing to the respiratory placements, which is the only confirmatory test. You are using either nasopharyngeal swab, oropharyngeal, mid-nasal, or anterior nasal swab. This is usually early in the disease. And the lower respiratory tract, like bronchoalveolar lavage and the sputum exam, we are not allowed to do induced sputum because this is an aerosol generating procedure, so it is not yet recommended. And this bronchoalveolar lavage or lower tracheal aspirate or pulmonary aspirates or sputum are recommended only in patients who are in pediatric intensive care units, and this is in the advanced form of the disease and in the late stage of the disease. However, despite symptom recovery, we may get positive PCR positive in the nasopharyngeal swab even around 2 weeks of durations. And big viral shedding occur early in the course of illness. And most of the genomic replications was not observed beyond 1 week on respiratory samples. And all viral cultures beyond day 8 definitely were negative despite positive PCR testing. So patients are unlikely to be infectious beyond 1 week, and we need to find newer tools to judge the infectivity beyond symptom recovery. However, potential risk for factors for severe diseases is that infants below the age of 1 year, chronic pulmonary disease, including moderate to severe asthmatic patients, patients with cystic fibrosis, with primary serial dyskinesia, childhood interstitial lung disease, bronchopulmonary dysplasia, or bronchiectasis. Also, cardiovascular disorders significantly affecting the circulation or immune compromisation, whether primary or secondary form. Plain X-ray is usually less sensitive than the high-resolution CT, and about 1/3 of cases you may get only plain finding, and it is less sensitive if compared to high-resolution CT. And bilateral distribution or subpleural, peripheral, and lower are the typical finding of the X-ray finding, like in these situations. We get bilateral ground glass opacifications and even non-homogeneous opacifications. And normal X-ray chest definitely doesn't exclude the possibility of COVID-19. For the pediatric high-resolution CT chest, in a very small study, CT chest performed only 60% children have ground glass opacifications. But however, this is done on just a 12 group of patients. But in a large cohort study, definitely we get a very important issue is that only 1/3 of patients have an abnormal high resolution CT finding. And the ground glass opacifications are the most common. And another Chinese report, but they are not concluding whether they depend on X-ray chest or high resolution CT chest. This is not yet well clear in this paper. 70% out of 134 children have an abnormal CT or X-ray chest finding. This is an example of how pediatric high-resolution CT is different than in adults. We get less number of ground glass opacifications, which is usually peripheral or subpleural, bilateral, and lower or mid-lung zones, and also multiple, and usually preferring the posterior basal segments. In pediatric age, they are smaller, fewer in number, and present at the same site. And also we get less number of pulmonary lobes are affected if compared to adult, and significantly lower rate of positive CT finding. And we get bilateral posterior basal, small ground glass opacification, and the peripheral. And again here, bilateral ground glass opacifications. What is very characteristic on CT pediatric age is the presence of halo sign, which is reported early in children when compared to adults. And what is actually halo sign? Halo sign is a central core of consolidation surrounding with ground glass opacification. This is usually present early in pediatric age if compared to adult. And also we can get bronchial thickening and the peribronchial vascular opacifications with less crazy paving pattern if compared. And this is example of ground glass opacification peripheral. This is an example of halo sign. And this is typically that halo sign in pediatric age is an early phase, then proceed to ground glass opacification in the progressive phase, and then proceed to consolidation in the developed phase, which is a little bit different. So the typical finding is the bilateral, peripheral or subpleural, ground glass opacifications, multiple mid and lower lung zone with the presence of halo sign early in pediatric age. This is an example of the halo sign, how we have a central core of consolidation surrounded by ground glass opacifications. Again, central core of and surrounded by ground glass opacification again. And the reversed halo sign in which we have a ring of consolidation in which we have surrounding a core of ground glass opacification. Again, we have a core of a ring of consolidation with central core of ground glass opacification, peribronchial thickening, and this is conclusively wise. Children are less infected with COVID-19 than adults. Severe and critical cases are much less in children compared to adults. Mortality in children are much less compared to adults. Children have shorter course of the disease. Lymphopenia is less common in children compared to adults, and radiological signs are less prevalent in children than adults. And thank you. And I'm sorry that I'm exceeding my time by 4 or 5 minutes.
Thank you very much, dearest Professor Nader, for this comprehensive, illustrative, and educational as well, as usually we enjoy, and you are always admire us with this. I think all the audience have a lot of questions, but I'm sorry, you are going to postpone all the comments or any inquiry after the last lecture. Now it's our time now to shift to the most important point after knowing the presentation and the differential diagnosis of the disease. This disease, as I told, is long time being with us, but we did not notify it until recently. And we are going to live with this virus for a longer period than expected because no benchmark, as we said. Our dearest Hamza, the doctor and the eminent and the dynamo of infection control in our area, not only in Saudi German, but they used to have his experience with the Ministry of Health. Dr. Hamza is CIC accredited from Canada, and his practice here really was amazing and surprising to have a very, very strict control of the staff, because you know the staff are more exposed, and we have from this point to appreciate all the effort done in our hospital from the administrative part and from the medical and paramedical, including the staff nurse who subsided us safely during this corona era last 3 or 4 months. Please, Dr. Hamza, it's our time to enjoy another taste of corona with you.
Assalamu alaikum. Good afternoon, everybody. It's my pleasure to join this webinar with all these mentors and brilliant physicians. First of all, I just want to highlight some of epidemiology aspects of COVID. In this presentation, may give some awareness about COVID-19 or SARS-CoV-2 to update the audience about the magnitude of the problem and communicate our preparedness in Saudi German Hospital Medina toward COVID-19 and to highlight some protocols of COVID. As Dr. Nader mentioned, actually his informative presentation, it is enveloped positive strand RNA virus. Also, some are pathogenic to human and some non-pathogenic to human. And we experienced here two types, SARS-CoV-2 and MERS-CoV, which is well known here in Saudi Arabia, which is also from genera of coronavirus. Actually, novel coronavirus, it was before called novel or Wuhan or Asian coronavirus. Now it's a new strain of coronavirus that was very identified as in clusters of pneumonia cases in Wuhan. And most of cases have had exposure to large seafood and animal markets. First, this is the historical of the COVID-19. First of all, it was reported some cases of pneumonia. It was no unknown virus, and then the Chinese scientists, they announced that this virus is different from the other known viruses like MERS-CoV or SARS-CoV that they were discovered before, and then announced this is completely novel or different coronavirus. And after that, it was spread and the action started in all over the world. Actually, this comparison between known or we heard about the types of coronavirus, some three types. SARS-CoV, which was before also in the world in 2002, and it ended at that time and left about 10,000 injured people or infected people, and mortality rate at that time was 10%. Actually, also there was no vaccine, no treatment. Here in Saudi Arabia, we have the endemic type, which is MERS-CoV or Middle East Respiratory Syndrome coronavirus, which is transmitted through the camels and well known it is a source or vector for this virus. And still we have already 2,494 cases up to now, and 35% mortality, because actually this high mortality because the Saudi Arabia was the first point that this virus has been discovered, and also there was no known preparation for this virus. The new coronavirus or COVID-19 up to now, as we see in this statistics, up to now, all over the world, it is about 13 million, and the mortality about 600,000, about 5%, 4 to 5%. In Saudi Arabia, actually, the infected people among about 30 million population, about up to now is to 230,000 up to now. And actually, the mortality from those viruses, from this virus, was about 2,100, about less than 1%. Yeah, if we can see the internationally, the mortality rate is 4 to 5%, while in Saudi Arabia, less than 1%. That means we can see from this figure some indicators that the surveillance in Saudi Arabia was very good, and actually those cases and the testing percentage was done actually in large scale. Second thing, also we can see this can give also an idea about the healthcare system. and up to now we are discovering about 3,000 infected people every day, symptomatic and asymptomatic. Actually, the method of transmission is zoonotic primarily, human to human. Up to now is well known, asymptomatic and symptomatic. The transmission or the mode of transmission is droplet, but in some cases it's airborne. Now this is debate in WHO between and the others if there is it is droplet or airborne. Actually, up to now there is no evidence that it is airborne, but some procedures that can make what's called aerosol generating procedures like ventilation, like ambu-bagging, like swabbing, tracheal intubation, non-invasive ventilation, tracheostomy, cardiopulmonary resuscitation, this can lead to airborne droplets. So actually, it begins with case definition of surveillance. How can we discover the cases? This is the most important. Without even testing, you have to suspect the case if the patient has acute respiratory illness, like fever, either measured or by history. This word is very important, that measured, that if you take the thermometer and you measure the temperature is above 38, for example, this is measurement. But some patients take antibiotics, so this lead to a decrease in temperature. But by history that he has high fever, so it's also suspected. Cough, shortness of breath, this is one case definition. Second case definition, patient has sudden onset of the following: headache, sore throat, rhinorrhea or diarrhea, but with epidemiological link. That means if the patient has only one, like fever, cough, shortness of breath, and on those period of outbreak, this is enough to be suspected. But if he has sore throat or headache, or just a headache, just a sore throat, rhinorrhea, he should has epidemiological link, like had contact with a confirmed COVID-19 case, or lived or worked in a facility known to be experiencing an outbreak of COVID-19, or any admitted adult patient with unexplained severe acute respiratory infection. That means it's not a community acquired or hospital acquired pneumonia, but it is not H1N1. It is non-MERS-CoV, so it is highly suspected for COVID. So fever is frequently reported between 77 to 98 in elderly people and with severe comorbidities. How can we define the close contact to a patient? It is being within 2 meters of confirmed case for more than 15 minutes. So the distance is less than 2 meters, and the timing is more than, or contact time is more than 15 minutes. This is what's called contact time. The virus can infect less than 15 minutes has low risk. Less than 2 meters or more than 2 meters also has low risk. Direct physical contact with a confirmed COVID, like household contacts, living in the same house or working in the same place without wearing a mask or wearing a PPE. Or giving direct care to, like the nurses, like the doctors, this also close contacts. Living in a household, sharing a room or meal, or sitting within 2 rows in any direction of confirmed for more than 15 minutes. Actually, the general infection prevention and control precautions is the gold standard in this, because as we know, this disease, all what can we do now is prevention and control. Treatment still under processing, vaccination is under processing. So standard precautions, and this standard precautions is very long subject and need a lot of time. But we can focus on some measures here, like respiratory hygiene and cough etiquette. This is actually for long time infection prevention and control measures was taken as maybe as advice, as word, but now it is reality. It is the measures that should be followed, and this is the only methods or procedures we have to control the situation. Cough etiquette, like teaching the patients how to contain his secretion, like using surgical mask, using tissue and discard this tissue in most or nearest receptacles. Visual alerts in each and everywhere, like in posters, like in media, in television, in waiting areas, in screens. This is very important. Also, I am showing here some pictures that we adopted in our hospital. This is put in main reception. This is to show in English and Arabic or maybe other languages what is the measures to be taken, and should tell the reception about these symptoms to notify the doctor and to notify the ER that we have suspected cases. Also, most of the healthcare workers, nurses, doctors, technicians should know what is the 5 moments of hand hygiene. Hand hygiene is the single most procedure can prevent the infection. More and often hand hygiene, either use soap and water, either use alcohol, and those 5 moments, like before touching the patient, before making aseptic technique, after body fluid exposure, after touching the patient, or after touching the patient's surroundings. And we should know what is the patient surroundings, like medical file, like tables, like anything belong to the patients, because we know this disease can be transmitted through the contact and droplets. So this droplet can stick into the surfaces, and the only way is to clean those surfaces with disinfectant, approved disinfectant, and also to clean your hand. So as we said, placement on the precautions per WHO, it's droplet precautions, airborne precautions also, and airborne precautions the most difficult precautions, that because it is very need very well prepared hospitals and facilities to deal with such infection. So negative pressure rooms, and this is the gold standard of prevention or engineering control and designing inside the hospitals. Negative pressure room. Negative pressure rooms are special rooms designed to have less pressure than the corridor. So the infection can't go out, or the breath of the patient can't go outside the room and infect the people outside the room in corridors and other areas of the hospital. And actually, it is costly and need special engineering, planning, and designing. So the patient, if he's critical and he's coughing, and you need to make a aerosol generating procedure like we mentioned before, like ventilation or others, so the patient should be in negative pressure rooms. When not available, so she should be put in single room with portable HEPA filter. HEPA filter states for high efficiency particulate air filter, which can make filtration for the air and for to prevent the viruses to circulate inside the room. So also what we have what's called ECH. This is ECH also in the design of this room is air cycle or change per hour. So this is this means how many cycle of air changing every hour to prevent stagnation of air inside the room and more infection. Also in a 95, what was one of the airborne precautions that actually many people are wearing the N95 doesn't fit for them, and it is not appropriate for them, and is not protective for them. So we have to have fit test. This fit test is done by through equipment, is simple equipment, bitter or sugary fluid, and if the participant or the healthcare worker smell or test this bitter or sugary test, that means it doesn't fit for him and he should wear another size. So there is three sizes of N95, which is small, medium, and large, and according to the brand model of the N95. Facial hair or bearded person actually doesn't fit for N95. That means we see some healthcare workers wear N95. It's not fit for them because you are bearded. It should you have to have shave the beard because the hair actually or beard hair prevent the fitting of the mask in your skin tightly. So you should wear what's called bubber or powered air purifying respirator, special respirator. Airborne precautions for neonate and the children actually begin with OB-GYN in the delivery room. Actually, if the mother is suspected case, so preferably to this mother should deliver in airborne OR. Actually, it is not available in many hospitals. If we don't have, actually, we should make it in OR or DR with HEPA filter, and also neonatal resuscitation. Neonatal resuscitation should be away from the mother, as Dr. Nader mentioned, that there is no evidence about perinatal transmission, but we should care for postnatal, for neonatal resuscitation to be away 2 meters from the mother. Also, breastfeeding is the best for the children. So it is not prohibited, but in certain precautions, if the mother can't find somebody to take care of her child, then should wear the full PPE or wear mask and doesn't have any contact with the neonate respiratory system. Also expression of milk or give it to a caretaker and take care of the mother of the baby. So the gold standard for swabs of COVID is nasopharyngeal swabs. Actually, oropharyngeal has lower sensitivity than nasopharyngeal. Before it was recommended that to be combined oropharyngeal plus nasopharyngeal swabs at the same swab to give more reliable result. Now they recommend nasopharyngeal swab at least to be taken for the patient with COVID. Actually, we also experienced some people, they took the oropharyngeal because it is actually easy to take it in maybe in stations, in any place in polyclinics, but the patient come as negative result after the nasopharyngeal swab. We discovered that it is he is negative, he is positive. Also, the patient should meet criteria for case definition, as we mentioned before, should evaluate it also for other acquired pneumonia or hospital acquired pneumonia like respiratory syncytial streptococcal pneumonia like Haemophilus influenza and the others. And also WHO emphasizing the influenza control effort to start because the people forget about the influenza and the influenza vaccine, and we maybe the mortality rate from COVID up to now is 600,000, but influenza mortality is more and more than this disease. Also, nasopharyngeal swab has a special technique, and the best can be done by ENT doctor. You shouldn't go above to the cribriform plate, but you should take it horizontally, like the picture shown, to be reliable up to 2/3 for the groove. Yeah, maybe 1/3 from the air and 2/3 from the nose. This is the space you should swab and to get secretions reliable for to contain the virus. We have here in Saudi Arabia reporting system hotline 937. This is give public information, and also we have also a health electronic surveillance network, and it's connected to all over the kingdom. And by unique number, which is the ID number, you can reach to any result for any patient. And actually, it is this ID number can given once to every citizen or resident. So you can see all the result, all history of his infectious history, either COVID, either MERS-CoV or H1N1. Laboratory diagnosis at this stage, and actually this is very good and very important, that laboratory testing not done in any private hospitals or centers, only done at the National Public Health Lab only. And this gives the actually to know the magnitude of the problem, because all and every patient will come to you on this system and register. So there is no cases escaped, and you don't know how much the patient you have. So every to national lab, and only this is permitted to do the test. We can see here this monitor is actually is recommended for any negative pressure areas or airborne isolation, and should be wall mounted, and should be actually measure the temperature, humidity, negative pressure inside the room, and air cycle per hour. Actually, the healthcare workers, and this is the this is very important, that now there is no retesting for the healthcare workers. They should back to the work if they spend 10 days without symptoms, or they spend 3 days after being symptomatic. That means if you are asymptomatic from the start, there is no risk for replication of the viruses, and you can back to work directly without re-swabbing. If you are symptomatic from the start, you can spend 3 days after these symptoms disappear, like fever, diarrhea, and completely resolve. And then you spend 3 days, and then you can back to your work if you spend also 10 days from the start of the swab. This is also we make in waiting areas in OPD, like social distancing. There is should be you have to keep minimum distancing between the patients, at least 1 meter. Also in corridors, also in pharmacy, in elevators. Triaging at first point entry of the hospital is very important, because this is like safeguard for the whole hospital. If you know the patient and you ask him about the question of symptoms, and questions of direct contact to a case or animals, and also take the temperature, it is very important to discover those patients before they are going into the services inside the hospital and infect everybody. This is also triage in hemodialysis clinic. This is triage for contractors company like housekeeping, because also housekeeping has very high risk, because some people are infected and they make very large outbreak in some hospitals and infected many people. This is the ER isolation room, and this is the anti-room, which you can wear all your PPE before you enter into the patient. Also, the hemodialysis negative pressure room. This is because some we have to care for special groups in the for COVID patients, because some patients they are in hemodialysis at the same time they are infected or suspected COVID. So they should have separate negative pressure rooms for them. Also, this is the ER. This is disposable sheets, linen disposable sheets. So So this disposable can be changed every after patient, and also the HEPA filters. This is portable HEPA filters, and also this is we can see here. This is designated X-ray, portable X-ray. The patient shouldn't also roam inside the hospital. X-ray portable machine should come to the patient in isolation and take the image of X-ray instead of the. We can see also in this picture the bubble that we talk about, that this is the instead of N95 for the bearded persons, that they are not fit for N95. Fumigation, also using hydrogen peroxide or high-level disinfection after the patient discharge is very important to cover all the surfaces and to prepare for the next patients. Also covering or disinfection of the cars transmitted the infection, they are used to transport the patients either suspected or confirmed. Ambulance or hospital transportation, disinfection everywhere using hospital approved disinfectants, mosque, auditorium.
YouTube. Dr.
Yes. And finally, I just wanted, this is the actually, because of time, but this is the disaster control committee that composed of all hospital administrators and key leaders of the hospital, which already managed this disaster very well, and we are still in continuous meetings. This is also one of the approaches that to make designated elevator for transporting the patients, designated staff for taking the swabs, negative pressure rooms in ICU, CCU, make sure of PPE and the supplies. Now there is take-home messages that it's very crucial to involve the top hospital management staff to ensure appropriate and timely support for all IBC preventive measures, continuous communication with all middle management to ensure availability of required IBC supplies with easy access all the time, to implement strictly and observe zero tolerance. That means nobody or no staff allowed to breach the infection control measures. Also to ensure active internal reporting system between the hospital department and IBC staff to follow the MOH guidelines regarding the proper identification, visual triaging. Staff health clinic play a major role in this situation. Staff accommodation isolation rooms is very important. Round of IBC staff, please ensure proper patient isolation to be implemented at proper time. All negative pressure isolation room should be used only for proper diagnosis. Finally, an ounce of prevention is better than a pound of cure. Thank you very much.
Thank you, Dr. Hamza, for this long presentation, which needs more time to satisfy every needs. Now we are going to have the Associate Professor, Dr. Amani, the member of the European Academy of Endocrine and Egyptian Society of Endocrine. And she's our consultant endocrinology and have been assigned as a COVID representative of the media department, and she have seen a lot of cases and she have got some experience because nobody have experience before that time. Please, Dr. Amani, come.
Please stop sharing. Please stop sharing.
Stop sharing.
Okay.
I would like to present my little bit experience regarding the COVID-19 and implementation of strategies in type 1 diabetes. Here are the symptoms that Dr. Nader has mentioned.
والله دي كانت صور قديمة.
دكتور حمزة ميوت بليز. دكتور حمزة ميوت.
دكتور حمزة ميوت عند حضرتك.
اتفضلي دكتور أمان.
Manifestations include respiratory symptoms, including common manifestations like cough and shortness of breath, and less common manifestations like rhinorrhea and sore throat, and other symptoms like fever, myalgia, fatigue, and headache and confusion. Less common like gastrointestinal symptoms like nausea, anorexia, and loss of smell and taste sensation. The chest X-ray findings were discussed in details by Dr. Nader, and the blood laboratory investigations were discussed also by Dr. Nader, so I will not go through them here. Here are the precautions that should be taken for every pediatric patient, not just the diabetic patients. We stress that the diabetic patients should take care of this precautions also. They should learn how to do hand sanitization, how to wear face masks, and how and the mothers and fathers the parents should be oriented with the manifestations of COVID-19 in order to start treating them before even getting to medical stuff. Here is what illness results in hyperglycemia. The infections results in the secretion of glucagon and cortisol secretion, increase these secretions, these are anti-insulin hormones, and this occurs, by the way, in both healthy and diabetic children. And this results in high blood glucose levels. In healthy children, this will interpret in the form of stress hyperglycemia, and this anti-insulin hormone will result in a relative insulin resistance and decrease immune function and increasing the inflammatory factors, resulting in more predisposition to infection. The lockdown that our patients suffered resulted in minimal impact on them, and some patients have some major impacts like less exercise, changing their dietary habits, having more snacking and consuming high caloric foods, comfort foods, and restricting their routine. Follow-up visits to our clinics, and this decreasing the availability of the insulin medical supplies of diabetes, resulting in some of the parents started to store these supplies. Some parents may associate doses with eating, like the insulin requirements in these patients, in our patients, should be increased if the patient is suspected to have COVID-19. Some parents may associate this insulin doses with eating, and if the child is anorexic or vomiting, they can stop giving insulin, which is a fatal mistake. Hyperglycemia is also common in the presence of intercurrent illness, irrespective of caloric intake. Therefore, never to stop insulin, and during the illness, try to maintain carbohydrate intake. This stress of being ill can increase the basal insulin requirement due to relative insulin resistance. The ISPAD has released some guidelines, new guidelines for the diabetic patients, which we will go through them rapidly in the next few slides. Children are not like adults. They are not experiencing severe clinical manifestations, and this is explained by Dr. Nader also. The evidence that children didn't have a different pattern or susceptibility risks compared to normal children, and there is concern only about the delay in the diagnosis of new cases of type 1, so they might present with more severe complications. In dealing with patients with type 1, we have to revise this chapter of sick day management and sick day rules for the parents. Sick day rules are known to all parents, how to manage the DKA, not how to manage DKA, how to manage DKA and hypoglycemia is for doctors, but how to manage hypo and hyperglycemia is mentioned in the ISPAD guidelines previously in 2018. Elevated blood glucose levels with absent or small amount of ketones. This will need to give extra doses of 5 to 10% of the total daily insulin calculated for this patient as short-acting insulin subcutaneously, and this can be repeated every 2 to 4 hours according to the blood glucose and according to the clinical response. For those who are on insulin pump, we have to increase their basal rate by using a temporary basal rate with an increase of 10 to 30% for 2 to 3 hours, or as longer as it is required by our children. When we have elevated blood glucose with moderate or large amount of ketones, ketonuria, then we can give additional 10 to 20% as an extra dose, 10 to 20% of the total daily insulin to be calculated also from the total daily insulin the child receives as short-acting insulin, and can be repeated similarly every 2 to 4 hours according to the blood glucose detected and the clinical condition of the child. The insulin doses can be increased more than this increments, this 10 to 20% increments in patients suffering from partial remission or honeymoon. As we all know that patients suffering from honeymoon, they are already on lower doses of insulin to avoid passing into hypoglycemia. So therefore, we calculate extra doses here according to the body weight of the child, not to the actual doses he is on. Now, how to control diabetes during COVID-19 era? We have to instruct our children to do more frequent blood glucose monitoring, ketone body monitoring, if it is present in their glucometers, monitor and maintain hydration with adequate salt and water, and treat any underlying illness or suspected symptoms symptomatically. Like if you have some fever, we have to treat as usual by antipyretic. If you have some vomiting, you can use antiemetics. It is just symptomatic treatment, no specific treatment is required. And we have to teach our children how to do proper hygienic procedures in order to avoid, this is required for prevention. Try to maintain their blood glucose between 70 to 180 milligram per DL. This for diabetic children. Blood ketones should be less than 0.6. They have to exercise daily and even at home. They have to take their 3 main meals and 2 snacks, and even we can increase them to 3 snacks if it is required. We can check the blood glucose frequently from 6 to 8 times before and after meals and manage accordingly. Change the dose according to these results, and we have to keep our hemoglobin A1C below 7 or 7.5. Never stop insulin, and I am stressing on never stop insulin because this is a common mistake the parents are doing. If fever exists, insulin requirements is expected to be higher, therefore don't stop insulin. It is required during infection. And the parents also should be aware of the alarming symptoms that necessitates referral to the emergency department. Blood glucose continue to increase despite these are the alarming symptoms to which we can refer our patients to the emergency. The blood glucose continue to increase despite of extra dosing we are using. Acetone breath odor becomes evident. Blood ketones are elevated if we have this facility in our glucometers, and the patient becomes confused or having exhaustion, tachypnea, cosmos breathing, having severe abdominal pain, persistent vomiting, or any neurological symptoms that appears. If patients with diabetes and having COVID-19 symptoms, then he should call the doctor after having a blood glucose reading, after having a ketone reading, and keeping track with fluids. What shall the child do and his parents at home before even calling for the doctor? They knew how to deal with this problem. They should drink plenty of fluids, non-caloric fluids, of course. But if they have blood glucose which is low, they can take 1 point carb, 15 grams of simple carbohydrate, and recheck the blood glucose after 15 minutes, and then recheck again every 2 to 3 hours. If blood glucose is high more than 2 times, then check for ketone bodies either in urine or in blood to avoid the DKAs. And they have to wash hands and clean injection and finger stick sites with soap and water. This is the algorithm we use in sick day management and for cutoff points for DKA, and according to the blood ketone levels, if they are more than 3, and from 1 to 1.5 to 3, and from 0.6 to 1.5, and this is the algorithm we use to use in our patients. As I said, the ISPAD have released new guidelines concerning COVID-19 in children with diabetes, which we'll go through them. Uncomplicated mild to moderate cases with diabetic ketoacidosis can be managed outside the ICU. This can be applied, this is for the management for DKA If a patient has got a DKA and we need to admit him to the ICU, before we categorize our patient, either he is a mild, moderate, or severe case. Mild and moderate cases can be managed outside ICU. This can be applied to high and limited resource settings, even in regional hospitals or in tertiary hospitals. We can use subcutaneous rapid-acting analogs instead of IV insulin for mild to moderate cases. Management of fluid and electrolytes should be done according to the DKA guidelines of the ISPAT 2018. Once DKA resolves, the remaining volume of fluids that is calculated from the start and the potassium replacement that is given should be given orally to the patient. The suggested starting dose of insulin is 0.15 unit per kg subcutaneous injection, rapidly acting insulin, 1 hour after starting the IV fluid management. This is exactly the same as the regular treatment. We used to fix 2 IV lines for this patient. One line we will start IV fluids in it, and the other line after 1 hour we will start insulin infusion. So we can start the insulin subcutaneously also in the same manner after 1 hour of the IV fluid insertion in the patient. And if the blood glucose falls below 250, exactly the same as the guidelines used for DKA management, if it falls beyond 250 or 30, we can add 5% dextrose to the IV fluids, fixed to them. Then subcutaneous insulin can be given every 2 hours until DKA resolves. The dose of subcutaneous insulin can be decreased to 0.1 unit per kg every 2 hours. When the blood glucose decreases by more than 90 per DL per hour, if to avoid passing into unnecessary hypoglycemias. Monitoring of the blood glucose should be done hourly, aiming to keep the blood glucose level around 200 till DKA resolves, and the basal insulin can be initiated once the DKA started to resolve. There are many questions that comes to our minds as doctors concerning COVID-19 and diabetes, but the evidence concerning these two questions is little. Are our children with diabetes at increased risk of infection with COVID-19? Still, evidence is scarce. And does the infection with COVID-19 yields more severe outcomes in our patients? And still, this question couldn't be answered within the research we have now. We have limited sources and limited references till now. So but a clear message, we should send a clear message to our parents and our children is that they should take care of themselves and avoid infection as much as they can. We still don't have many data to confirm that they are at increased risk or to confirm that they will get severe disease. Can COVID-19 cause diabetes? No evidence yet in children, but in adults, there are many papers discussing the condition. Stress-inducing illness can induce blood glucose levels to increase. So in critical patients having COVID-19, we have to monitor the blood glucose. The patient may simply pass from having stress hyperglycemia into diabetes, either type 1 or type 2. We still don't have enough data. People who are likely to get very sick with COVID-19 may be at risk of developing diabetes because they are overweight. And this evidence is in adults and not in children yet. We have some practical challenges for diabetes care. Just we are trying to keep our children outside of hospitals, avoid admissions, avoid getting them into hospital for any reason, for any unnecessary reasons. If admitted, try to get them safe outside the hospital without contacting infection in our hospitals. Importance and challenges of glycemic control during acute illness, and we have to control the blood glucose during any acute illness in a diabetic child, and he knows well, the parents knows well how to manage their children during acute illness. Education for the patients and healthcare workers about the new guidelines, and we have to promote the remote and reduced care using telemedicine, conferences, video conferences, calls, or even groups on WhatsApp and so on, in order to contact our patients and to solve their problems without coming to hospital or without coming to visit if this can be feasible. And we have also to prevent long-term burden, which including psychological burden. Stressing again on hand washing and social distancing, promoting health, including healthy diet, exercise, and mental health, communicating with our children and their parents through telemedicine. Contact numbers should be available, education, and providing timely care for them. We stress also on continuing regular medications like never to stop insulin, to control our blood glucose, adhere to the 6-day rules, increase the insulin doses when it is required, seek medical attention early for the acute and acute illness and diabetes complications. This for the DKA and hypoglycemias. Still, we have challenges with some patients. The usual clinic appointments have been canceled. The patients and the parents are afraid to seek help due to the risk of contacting COVID-19 infection. Patients are feeling unwell and don't want to leave home. Therefore, to solve this, we can use telemedicine. We can assure the patient that going to the hospital will not cause them infection, encouraging the parents to come to clinics and to maintain open communication with them to help monitoring for the complications away from the hospital. Finally, I am stressing on that we have to continue our routine vaccination schedule for our children and adhere to the routine vaccination. The adherence to the routine vaccination is crucial. Additional vaccines like influenza, pneumococcal, and other vaccines are indicated. No vaccine is still available for the COVID-19. So we have to give vaccines for other infections. We want to reduce the risk of co-infection. We don't know how mixed infections with COVID-19 behave, and to avoid the hospital admissions with complications of these infections as much as we can. So I am having some cases to share. Can I share it, Dr. Nabil? Or it's okay to share? Okay. We have case 1. Abdullah is 10 years old boy with type 1 diabetes. He's diabetic for 3 years now. No diabetes complications is recorded in his file. Thyroid profile and celiac screening was done only once 2 years ago and was negative. His weight is 40 kilograms. He started to develop low-grade fever, runny nose, cough, and diarrhea for the last 2 days. And then all this disappeared except for the fever that persisted and associated with bony pains and headache. 3 days later, he developed anosmia and loss of taste sensation. His mother called to ask what to do with his blood glucose. His blood glucose is kept all through above 260 milligram per dl, and most of the readings with no acetone in urine. No other symptoms could be detected, no rash, no vomiting. He's little less active than usual, but still there is a fever. His father had fever last week and loss of taste and smell sensations, and neither of them had done COVID-19 swabbing. So when revising the doses of insulin that our child is on, we have the basal insulin glargine is 10 units per day. His bolus, he's having boluses with the average, with the breakfast, he's taking 8 units Novorapid. With the lunch, he's taking 12 units Novorapid, and with dinner, 8 units Novorapid. His total daily dose is 40 units, which is equal to 1 unit per kg. Remember that his weight was 40 kilograms. Therefore, he's on 1 unit per kg per day. Therefore, his corrective dose is 10% of his 10% of his total daily dose, which is 4 units of Novorapid. Therefore, for every reading that is above 250, he should receive 4 units Novorapid every 2 hours or every 4 hours according to the response to the blood glucose. His carb insulin ratio to be calculated was 500/40 to be 12.5 grams. What is this carb insulin ratio? This is how many insulin, this 1 unit insulin can burn up to 12.5 grams. This is variable from one patient to another and should be calculated for every patient. Also, the insulin sensitivity factor is 1,800/40. 40, this is the weight, this is the total insulin, daily insulin, and it's equal to 45. What is this insulin sensitivity factor? This is how many units of insulin, this 1 unit of insulin is needed to burn 45 milligram per dl glucose, or to get rid of 45 milligram per dl glucose. So we try to reassure his mother, Abdullah, and tell her that her child is may have acute complications like hyperglycemia, ketosis, and DKA in the hypoglycemias, and he can be dehydrated. Dehydration can increase the risk of thromboembolism. No evidence of other risks in diabetes children, unlike adults. DKA is more likely to occur due to the delay of seeking medical care and the lockdown fear, no access to doctors. So what to do for Abdullah? We will manage him at home. We will try to maintain hydration, give antipyretics, do frequent measurement for blood glucose by using finger stick, or better use flash monitoring if it is available, and try to limit the glucose variabilities, the hypo and hyperglycemias, and that's it. He can, this is in spite of, he is a case of suspected COVID, but he can be managed at home safely and in simple way by the parents. And as usual. Mona is our second patient. She's 12 years old female, diabetic since the age of 8 years, 4 years now. Her last hemoglobin A1C is done 6 months ago, and it was 9. This means that she's uncontrolled. She's on NovoRapid according to her meals. For every 1 unit insulin she receives, for every 10 gram carbohydrates she receives 1 unit insulin, and she's on insulin glargine 18 units per day. Mona is suffering from, her mother has called because she's suffering from bad breath smell, vomited 3 times in the last hour, and I asked her to check her blood glucose now. 60 minutes after the mother called, she said that her daughter had rapid deep breathing and looks exhausted, and her blood glucose measured high on the glucometer. What to do for Mona? Then Mona should go to the hospital. She seems to have DKA. In the hospital, when she went to the hospital, her blood gases was, the pH was 7.1, the PCO2 was 18, and the bicarb was 12, and the basic excess was -14. Her urine analysis shows ketonuria and glucosuria, no bus cells. Her serum sodium was 130, her potassium was 4.5, and creatinine was 0.9 millimole. For Mona, we treated her as moderate case of DKA, and then according to the previous algorithm discussed, therefore her dehydration was assessed to be moderate dehydration. Her weight was 35 kilograms and her surface area was 1.1. So the total fluids calculated for her were maintenance plus deficit, and the maintenance and this fluids will be calculated for the next 48 hours for her. The maintenance is 1,500 per meter square, and this is calculated to be 3,300 milliliters over 48 hours, and her deficit was calculated to be 3,500. This is the addition of these fluids. The total fluids in the 48 hours is 6,800, and this is the rate of fluids was 141. The type of fluid is normal saline plus potassium chloride 40 milliequivalent per liter, and the insulin given subcutaneously every 2 hours at a dose of 0.15 units per kg, meaning 5 units, calculated for Mona to be 5 units. And then we re-evaluated her after 2 hours. Actually, her DKA resolved after 6 hours without admission to an ICU, only in a general ward. Our take-home message is to maintain the balance between insulin and food, and just don't stop insulin. Do frequent blood glucose monitoring. If diabetic and affected, don't panic. You will be cured. Go to the hospital only when emergency, but without panicking. Monitor the blood glucose for COVID-19 patients, and this monitoring for the blood glucose for COVID-19 patients might give us impression or give us the causal relationship between COVID-19 and the development of diabetes later on. Do swabs for all newly diagnosed type 1 diabetes, as it may be a cause of precipitating, like any other viruses present in the etiology of type 1 diabetes. It may be a cause for precipitating type 1 diabetes in our children. Don't ignore vaccination, please. And thank you.
Really very, very, very nice gathering of something not easy to express in 25 minutes. But this is Dr. Amani, and this is her performance as usual. Now we are going to go to another hot topic. Maybe it's not that much prevalent, but it is to be considered. It has around 100 cases reported in Europe. Some few cases maybe in Saudi Arabia, but as far as I know, it have an increasing and growing number in Egypt. And this is the MICS. This is a multi-inflammatory syndrome in children. And please, now we are going to represent one of the most eminent infectious disease consultants in Medina, Associate professor in Tiba University Hospital, and he is Canadian Board of Infectious Disease. That's Dr. Amir Shankiti, our dear colleague that is working with us in Saudi German as well. Please, Dr. Amir, it's your time to come, please.
Assalamu alaikum warahmatullah.
Alaikum salam.
Sorry, I couldn't share the video because I have a problem with the net, but I have my voice is clear. So I'll talk about, first of all, thank you, Dr. Nabil, and thanks for the organization committee for inviting me. And it's my pleasure to be with you today, inshallah. I will talk about multi-system inflammatory syndrome in children, and I think most of us as pediatricians heard about it after a few months from the starting of the pandemic. So the objective of the talk will be, by the end of this presentation, I hope the audience will be able to describe the epidemiology of we call it MIS-C, and describe the feature of MIS-C, and at the end we'll outline the management. So I have to disclose that I have nothing to disclose. So this is a slide summary of what has already presented by Prof. Nader about the COVID in children. So it's depend on the country and on the studies, present from 1 to 8% of all confirmed cases. In Saudi Arabia, we have around 8% of all confirmed cases in pediatric age group. So most pediatric cases are mild, as already explained by Prof. Nader. Majority are mild. Fever, shortness of breath is less common than in adult compared with the adult, which is about 93%, and few cases are critical, less than 2%. We were happy with this, and as pediatrician and infectious disease and ICU specialists, we were happy with this data and with this finding in coronavirus in children since the start of the pandemic in January and so on. That's what the situation till mid of April 2020, when a report came from London, described 8 children, which were they described as hyperinflammatory shock in children in COVID-19 pandemic. So it was a cluster of 8 children with hyperinflammatory shock, with feature was similar. It's like atypical Kawasaki with incomplete Kawasaki features, and also overlap with toxic shock syndrome. So all 8 children have fever more than 39. 7 of them have GI symptoms, diarrhea, and 5 of them have conjunctivitis, and 4 have skin rash. There is mild, or there is no pneumonia, okay? So all of them has elevated inflammatory markers, including CRP, procalcitonin, ferritin, D-dimer, and triglyceride. 3 of them tested positive for COVID, and 4 has family history of contact with COVID patients. All 8 patients progressed to warm shock, which need inotropes and respiratory support, hemodynamic support, and 1 of them died. So this was mid of April and was almost the first report come from UK. After that, more and more reported cases from different parts of the world. For example, this is this report published in Pediatric. It's about 2 cases from Italy, and another report from New York was described about 17 patients with almost the same features. So this the 2 kids was described from Italy. So they have if you see the picture here, this child was red, like swollen red lips, and has a mild conjunctivitis, non-purulent. So some features that overlap with Kawasaki disease, as some BTK in the hand, BTK in the foot, and some rash in the hand. The other patients almost have the same features. So with more emerging case reports from different parts of the world, this leads to alarm and warning documents was released from different health authorities, from WHO, from CDC, as well as from the European CDC. Okay, all what described this feature was about multi-inflammatory syndrome in children who has positive COVID-19 PCR or previous infection. After asymptomatic infection, they present after 4 to 6 weeks with this feature, which looks like Kawasaki and overlap with the toxic shock syndromes. So there is different names for this syndrome. So they call it MIS-C is the name used in US. In Europe, they use pediatric multi-inflammatory syndrome, BMIS, and there is another one, pediatric inflammatory syndrome associated with COVID, with SARS-CoV-2, and pediatric hyperinflammatory syndromes. So with this more case, this is the proposed case definition from the different health authority, from the first one from the WHO, this one from the CDC, and this one from the Royal College of Pediatric and Child Health from UK. So this case definition most likely will change with the time, just because more evidence and more cases will be reported. For example, just a few weeks ago, the case there is 2 cases reported, or more than 2 cases reported in patient who's in early 20s, so outside the pediatric age group. So when you look to the case definition, compare the WHO case definition with the CDC case definition, it's almost the same, all about to have features, fever, should have fever, and the age group is different, the WHO up to 19, for the CDC up to 21 years. So, and to have more than one organ involvement, okay? Plus evidence of SARS-CoV infection, either positive PCR or previous infection with positive serology. For the Royal College of Pediatric and Child Health in UK, they did not mandate for positive SARS-CoV PCR or serology, and they just linked it during the pandemic when any child presents with this feature, which is not typical for Kawasaki disease or partial Kawasaki, should be considered as suspected case. Okay, so and should have the more 2 or 3 organ involvement, and should have signs of high inflammation, ESR, CRP, or other inflammatory markers, and you have to exclude other causes. So make sure he doesn't have toxic shock syndrome from Staph aureus or other infection, or streptococcus or group A streptococcus. Okay, and look for the evidence of SARS-CoV infection, PCR or serology, or if there is contact, family history of contact with COVID-19 patients. Okay. When you compare MIS-C with Kawasaki disease and toxic shock syndrome, this is a nice study published in JAMA, I think last month. They describe COVID-19 MIS-C in 58 children from UK. And then they compare this 58 patients with the previous cohort of patients with Kawasaki disease and toxic shock syndrome. What they found, for the age group, children with MIS-C tend to be older compared with the Kawasaki disease. Usually Kawasaki disease in children less than 6 years of life. This about around 10 years of age. White blood cells neutrophil count did not differ much, but when you look to the C-reactive protein and the inflammatory markers is much higher in MIS-C compared to the Kawasaki disease and toxic shock syndrome. Okay. The same thing for other inflammatory marker, ferritin tend to be higher in MIS-C. The same thing for troponin. So the cardiac involvement and the cardiac injury is higher in MIS-C compared to the Kawasaki disease. Okay, and I will explain that more. The same thing for D-dimer. So as we know, the patient with the COVID-19 from the pathogens, they have higher risk for coagulopathy, and this is the same thing with the patient with MIS-C associated with Kawasaki disease. So a child with MIS-C compared to the Kawasaki disease, most of them, about 80% of them, present with some GI symptoms, diarrhea or vomiting, and some neurological symptoms like headache, confusion, or other symptoms. About 50% of them present with shock, while in Kawasaki disease, about only 7% present with Kawasaki disease shock. More cardiac dysfunction compared to the Kawasaki, which in the Kawasaki with IVIG, as you know, it's about 4% with IVIG to develop aneurysm, and even if aneurysm happens, usually it is small. While patients with MIS-C, about 50% have some cardiac injury. They have lower platelet and lower absolute lymphocyte counts. When you talk about pathogenesis, what's happened? So if there is genetic susceptibility, it's interesting that COVID-19 started in East Asia and in China and the countries around China. However, the reported cases about MIS-C is huge, most of them from Europe and from UK, and usually from the Black and Hispanic, When you talk about Arab ethnics in our countries, I didn't find any reported cases, but from personal contact with the colleagues in the Gulf area, there is cases. Up to my knowledge, more than 10 cases so far, but we need published data, and I couldn't find published data so far. It's most likely post-infectious because most of the children have contact positive serology or contact, though few of them have positive PCR active infection. And it seems abnormal because most of them have localized hyperinflammatory response. And most of the cases, for example, in UK, it's happened after 4 to 6 weeks after the community surge. So in Saudi Arabia, we have our community surge. We are around the community surge maybe 2 weeks ago. I don't know whether we'll start seeing cases in the next 2-3 weeks. We don't know, we have to look. And most of them have evidence of COVID-19 infection, either serology or contact or positive PCR. When you look to the manifestation, this is just a summary from up to date. So for the reported cases, all of them has fever, okay? And GI symptoms significant, more than 2/3 of them have GI symptoms. Interesting, they have some neurological symptoms. Respiratory symptoms, pneumonia is rare. However, when they present with respiratory symptoms, usually it is related to the shock, okay? To the hyperinflammation rather than pneumonia itself. So shock, I said more about from 40 to, depends on the reported cases, from half to up to 80% of them. Criteria for complete Kawasaki, about 50% have fit criteria for complete Kawasaki. Myocardial infarction, dysfunction, more than half of them have myocardial dysfunction, either arrhythmia or poor left ventricular function. When you look to the lab, lymphopenia is significant, okay, and as well as the inflammatory markers. Cardiac injury, high troponin, more than 50 to 90% have abnormal cardiac enzymes. For echo, about 50% have decreased left ventricular function. Coronary aneurysm, almost about the same thing, about less than half of the patients. So when you talk about management, where to manage these patients? Should we admit any patient who presented with fever, skin rash, conjunctivitis with the COVID, or should I send them home with a close observation? So still we don't know much about this disease, and I will discuss algorithm. So if there is a place to admit the child and observe him safely in the hospital, that's better, especially if they have high inflammatory markers. If there is normal inflammatory markers and still you can observe him as an outpatient and close follow-up, that might be possible. But if there is high inflammatory markers or signs of severe disease, they should be admitted and even maybe in ICUs. You have to have multidisciplinary team. So especially ICU, if they are critical, ICU team, they have hemodynamic stability, maybe need ventilation and inotropic supports. Antibiotics, because still it can overlap with toxic shock syndrome, it can overlap with sepsis, we don't know. Usually start antibiotics till we confirm the diagnosis and de-escalate if you ruled out other bacterial infections. Antiviral, even in the COVID-19, the rule is still uncertain and the evidence is not clear. Whether to start or not, this can be case by case, but case by case evaluation. For IVIG, for any patient who has complete Kawasaki disease, complete Kawasaki feature should be managed as Kawasaki disease, okay, with IVIG and aspirin. If the patient has incomplete Kawasaki or has incomplete feature, IVIG, it's one of the drug, can be one of the first line to be tried in these patients. Though the evidence is limited, but most of the children published, they use IVIG or steroids. When you talk about venous thromboembolism, should we use systemic anticoagulation or should we use aspirin? Patients with Kawasaki disease should be treated as Kawasaki with Kawasaki feature, should be treated as Kawasaki with aspirin, inflammatory then antiplatelet dose, and patient who has left cardiac function and with COVID-19 may be at risk for thromboembolism, so might benefit from anticoagulation, and the better one to use is low molecular weight antiheparin. When you talk about immunomodifying therapy, glucocorticoid or monoclonal antibodies like IL-1 inhibitor or IL-6 inhibitors, whether to be used or not, evidence is very limited. And it's usually used in the child who has shock, who has severe illness, and it's used, or child have like cytotoxic storm, severe inflammation, very high D-dimer, inflammatory markers and shock, And the first line to be used usually glucocorticoid, prednisolone, for example, or maybe sometime pulse therapy. If they did not improve or there is contraindication, we may use the other immunomodulator like IL-1 inhibitor or IL-6 inhibitor. And however, the evidence is very limited, and this only based on some expert opinion and some guideline from here and there, but still the evidence is limited. So this, for example, the two patients who was reported from Italy in pediatric journal, if you can see, first patient received IV steroids and the other one received IV, IG, and steroids. After starting steroid, the fever, which was ongoing here, there was difference. The fever subsided and the inflammatory marker also started to improve. The same thing when they use IV, IG steroids. So the first line, the patient was in shock or the severe first line is IV, IG with steroids, plus minus steroid or steroid plus minus IV, IG, and then anti-inflammatory other IL-1 inhibitor or IL-6 inhibitor if they did not improve. However, we still need more evidence to, and I think with the time this will have more clear evidence. Okay, this is an algorithm from published from New York and pediatric cardiology. So it's very nice. So if the child presents with cardiogenic shock, or present with symptom of a life with Kawasaki disease, admit ICU, do full investigation, do everything. If they have evidence of positive PCR, may consider antiviral, though the evidence is limited, and give IV, IG, especially if the feature is overlap with Kawasaki disease. Patient who has typical Kawasaki feature should be treated as Kawasaki with plus minus glucocorticoid. Patient who has myocarditis, cardiogenic shock, or is in severe shock, should be treated with IVIG plus maybe steroid, regular or pulse therapy, and may consider other IL-1 or IL-6 inhibitor with consultation with rheumatology and infectious disease. Okay, the patient who present mild, who doesn't have symptoms, very mild symptoms, can be closed, observed as outpatient. First, obtain lab to make sure that they doesn't have high inflammatory markers. If they don't, for example, PCR less than 30, you can send them home with a close observation. If there is high inflammatory markers, better to admit and observe as inpatient. If inflammatory markers abnormal, you then obtain echocardiogram and obtain other workup to make sure they are not in cardiogenic or there is no cardiac involvement. When you talk about outcomes, data is limited, still very reported case from here and there. Most children survive in the reported cohorts. However, there is several deaths. From personal contact, I heard about 2 patients who died already, unfortunately. And from, there is 230 cases suspected with MIS-C reported from European CDC, and there was about 5 deaths among them. So in conclusion, MIS-C is a new syndrome associated with COVID-19. Still we'll learn about it at the time, and we'll have more evidence as more cases appear. For the local data is very limited, but we have to look forward to it and to be sure not to miss these cases. It's associated with significant morbidity. Mortality is still low for the reported cases, but it needs close follow-up. We need more evidence to determine the effect of different treatment and the outcomes. Thank you very much.
Thank you, Dr. Amir, for this actually dangerous, but very considered in the differential diagnosis with other criteria set. And this will raise the points of having a disease variant, MISC, or associated MIC with COVID. This is as comorbidity with the adults who died from COVID itself, or it is associated illness differently. Now, the treatment you mentioned is going with Kawasaki more or less the same. And this is what will be the question at the end of the talk of Dr. Asoha with Professor Nader, if he's available, is still with us because of the no agreed management now. So it will be his concern. Last but the most, and not the least at all, the dessert of our heavy meal presentations with dearest Dr. Soha Galal, the pediatric registrar and nutritionist with the Boston grade of program of feeding of children. Dr. Sao represents what's going on with the feeding during the COVID era, whether before or after or during the lockdown. Please, Dr. Sao, introduce yourself.
Assalamu alaikum wa rahmatullah. Good evening to all of you. And it's an honor to be with all these professors in webinar. Welcome all the audience. There's nothing left to say, but I will try to to be in the desert as Dr. Nabil told. Very short, very light, inshallah. I will be talking on infants and young children feeding during the time of COVID. As we know that the WHO recommended the infection prevention and control measures with the lockdown and very limited sources to the families going to the market or to the health facilities. So they need information and support in feeding their children. So let's go and open some recommendations for them. Let's start with the golden rule. For the mothers, as they are the caregivers most of the children, let's stress on this point and highlight it, the breastfeeding. We will advise all the mothers, even suspected or confirmed at home, to follow the respiratory hygiene during feeding and to continue their breastfeeding their babies. There is no evidence that the virus has been detected in the breast milk in the confirmed or suspected mothers. But if the mother is severely ill or having complications, we will not also stop the breast. We can use the expressed milk by all the precautions and safety precautions. Here is point also, if we will use the expressed milk, we will limit the number of caregivers giving the feeding to the infant. Only one person is enough to be responsible for the feeding. What about the pregnant woman? There is no evidence that the pregnant or lactating mothers are at higher risk to catch the infection than the general population. We still don't know if the pregnant woman even can pass the virus to the fetus or during delivery. The virus was not detected until this moment in the amniotic fluid. Is a skin-to-skin contact allowed between the mother and the baby? Of course it's allowed, but with all the precautions. Washing the skin, washing hands, wearing the mask, if the mother is confirmed to be positive. But it's unlikely that the virus will be transferred through the skin contact. And the benefit from the breastfeeding is more important than to consider the infection. Protecting and supporting feeding at home. We have to support the families, what, when, and how to feed their young children, especially during the complementary feeding period, because this is one of the most important days in the life of the children. We will use all the communication measures to transfer our messages to the parents and to the caregivers. And we will recommend the safe hygiene before, during, and after preparing the food at home. Delivering feeding service. What does that mean? we have to focus to reach the infants and young children in all our programs, even if the government is having programs or projects to reach the population in feeding education. We have to focus on the infants and young children, and we have to support also the government to monitor any violation will happen during this period of time during the lockdown and in the pandemic, because some companies may do some violations to distribute their formulas, and we have also to stress not to use the artificial milk formula except under its conditions and its indications. Advise also the caregivers at home and the parents to use the online shopping for food as much as they can, and to limit the physical shopping. What about our role in the health as a part of healthcare system? We will facilitate the infant and young children feeding counseling and the psychological support they need. We have many communication, social media, even video calls in the hospitals with appointments, and we will improve the access and facilitate this contact between us and between the parents. Also, we will have a party. We will participate in programs and services, even at home, consultations at home. If needed, and to give the children vitamins, minerals, supplement feeding if needed. What's different in feeding a child with COVID-19? In general, the children are at low risk to catching the COVID-19 infection. Among the few cases confirmed, they are having mild and or asymptomatic illness. There is some percent with severe illness, of course, but so we will follow the normal guidelines for feeding according to their ages, and also we will close monitoring the growth of the patient of the children's and their well-being to detect early any delay in the growth or weight loss or wasting. Okay, here's some tips and tricks to give to mothers and to answer their questions and concerns during this period of time. Just give this message to any mother asking what to feed. Make sure that you are giving healthy food. It's not easy, but try. You have to try every day, every time you are giving food. Make sure your child is eating healthy fats found in fish, avocado, nuts, olive oil or corn oil. Give your child the white meat because it's in general has low fat. Don't give the processed meat at all because it's rich in fat and salt. And don't give the fast food and fried food or frozen food. I know this is not too much practical for all of us. We are mothers and fathers also. But we will try as much as we can to limit this. Limit your child also daily intake for salts and give always the ionized. Make sure when you are buying the salt, it is ionized. Don't give the soft drinks at all. This is not allowed under any negotiation with the children. Give the fresh juice in spite of, and always remember that if you give a fresh fruit, it's a better snack than anything. Don't give too much sweets or cookies or chocolate. But don't stop, don't avoid. This is difficult. But you can negotiate with your child. You will give a small piece of a chocolate and he will eat his vegetables or he will eat his fruit. Cook at home. This is the best way to be good cookers. And to explore ourselves in the kitchens to improve the quality of the meal we are giving. It will be more nutritious, and don't take the children to eat outside. I know also we are waiting. We always was waiting to open this lockdown to go outside, but limit the eating outside. If you want to eat outside, please take all the precautions needed, the distance, sorry. And don't, sorry. Watch the calories you are giving the food, of the food you are giving, and make the preparing of food fun at home. Allow the children to go to choose what they eat, to participate in the preparing the food. This will make them happy and they will eat what they made by their hands. Here are some also advices about fruits and vegetables. For fruits, for the toddlers between 2 and 3 years, they need 1 cup of fruit. Almost between 4 and 13, please give 1.5. Up to 18, give 2 cups of fruit. This is not too much. If you count, it's not too much. You can convince your child to have. It's almost the same also, but try always to choose the leafy green colored, which will make him happy when he eats. For proteins, serve 2 or 3 portions per day and make the fish at least twice weekly. This is, of course, very important also, and it's recommended for all the children above 5 years. For milk, serve 3 portions per day. This includes yogurt. If your child don't like milk, give him yogurt, give him laban, give him anything of this with flavor. Don't overcook the vegetables, of course, not to lose the vitamins. If you use the canned food or the canned vegetables, please make sure it's not added sugar or salt. And the most important point also I want to stress on, to make sure that the children are having enough water during the day. They will not feel thirsty all the time, lazy with the mobiles, with the tab, with the TV. Offer them the water, put beside them a bottle of water to drink and to have enough water to be well hydrated. This is important to the immune system, of course, all of us know. Please, always when you are buying any food at the market, check the nutrition information written, the caloric amount in it, the fats, the sugar. This is very important to choose the food, the right food. At last, I want to just to take these messages that we will always support the breastfeeding and healthy complementary foods, whether we are in COVID or not COVID. This is golden rule, like I told. Mother with suspected or confirmed are allowed to give breastfeeding and to give care to their children with all precautions. This is psychological. It will be psychologically good for both the mothers and the children. And we will always focus in our any programs for protection or giving the service on the infants and young children. Always make communication between you and the parents and the caregivers through all the social media available. That's all. Thank you for all of you. Hope I was light, and thank you for all the audience. Thank you.
Thank you. Thank you with the last and the simple but زي ما بيقولوا السهل الممتنع. الرسالة دي وصلت لي حالا من الدكتور العظيم نادر بفصيح. الدكتورة سهى بتقول كلام بسيط جدا لكن السهل الممتنع، وشكره في الجروب اللي موجود دوت لم يكن ليكون لولا وجود المظله من الدكتور نادر باشا اللي معانا دايما في كل اختباراتنا في المدينه مع السود الالماني. وده الحق والاحقاق اقوى مؤتمر صدر ومناعه وحساسيه بيتعمل في الشرق الاوسط بلا منازع هي مؤتمرات الدكتور نادر. يكفي السنه دي للاسف لولا كورونا كان عنده 68 انترناشونال سبيكر في جامعه عنده في اسكندريه. وانا بستأذن بس ما تبقى لنا من وقت اذا كان الدكتور نادر بي يحب يضيف حاجه او الناس الموجوده. بس انا في كومنت صغير مع الدكتوره سهى اللي هو الاورال انفكشن اورال روت انفكشن از فيري مينيمال عشان خاطر الاسيديتي بالذات واللي في الاستومك although it is can be transmitted from the feces if present parts of the virus self. وفي نقطه اخيره كنا احب اقولها ان احيانا بنلاقي البي سي ار is positive for longer time than expected, and it does not mean infection. It is the reaction for the particles or the parcellin from RNA. عشان كده الناس بتهتم جدا فوق بالكلينيكال وما نبطلش الحركات والالتزامات الاحترازيه اللي الناس بتستسيسها، وهي دي اهم حاجه مع الماسك. اخيرا انا بشكر كل الزملاء اللي حضروا معانا وجميع الزملاء اللي اشتركوا معانا في الاسئله، وانا جاوبت معظم الاسئله مع الاخوه المعنيين. فاضل ending of this seminar with Dr. Nader. Please, Dr. Nader.
Actually speaking in Arabic and in English, I am so impressed by all the speakers. I get a lot of informative data, and I got a lot of more and more informations from all the speakers, starting with Dr. Hamza, which gave us a very important resume about infection control in a very professional way. And then Dr. Amani, I think that she gave us a very important informative data about diabetic patients who are not yet few number of patients, but we have definitely a good number of diabetic patients, and so how to deal with such a group of patients which are definitely met in practice. And then Dr. Amir and I got a very impressive and very interesting presentation to me, and I got him. Please, I thank you very much for these informative presentations. And lastly, Dr. Soha, which give a very simplified way of talk, which is very informative and very beneficial to all the mothers, all the parents, all the doctors. And finally, I am so happy to be with you, and I hope to be invited all in all in the upcoming ECPP, inshallah. All of you, all Saudi German staff are invited to the ECPP. And I want also to inform that it will be this year in a virtual conference, and you can join it with all the international speakers in the second week of October, inshallah, 2020. And it will be a virtual conference with the same organizing company of the ERS and most of the European companies, and you can enter through it virtually, and you can attend all the sessions with all the speakers as if he is in real life. And thank you a lot. Many thanks.
استاذ علاء بعد اذن حضرتك كومنت صغير ان في اسئله كتيره بالنسبه للساعات والاعتماد والشهادات. بليز مستر علاء.
طيب بالشهادات ان شاء الله بتمنى انا من جميع الحضور ان شاء الله all the attendees please you will receive evaluation sheet, please fill it, and you will receive your certificate directly in the email. And for the CME hour, inshallah, it is 2 CME hour, inshallah, it will be in your Mumaris Plus account, inshallah, within 10 days. And for خلاص نحن دحين حنختم دكتور، فعاد اسمحوا لي انه اشكركم جميعا دكتور على الويبنار الرائع.
في كومنت صغير دكتوره اماني تحب تقدمه عشان سؤال كان جاي لها بالنسبه هل في any genetic predisposition with coronavirus for diabetes. دكتوره اماني.
No evidence yet present, and thank you for the question. It's an interesting question. But no evidence is sufficient to say that there is a more susceptibility in type 1 diabetes for COVID-19 infection. and still it's early to say, so we have to do lots of research to detect it إن شاء الله.
دكتور حمزة تحب توصل أي رسالة أخيرة قبل ما نقفل؟
Thank you very much for all physicians, for Dr. Nader from Egypt. Actually, he was value add to this webinar. Thank you for Dr. Nabil. He's our mentor in pediatric, and actually we spent very, very respected and good time with Dr. Nabil. He was one of the eminent doctors in the hospital. Thank you for Dr. Amani, Dr. Soha, the active people in the hospital, and actually day after day they build the trust here in the German hospital with colleagues, with patients, with everybody. Thank you for Mr. Ala for arranging this webinar, and as always brilliant and shining. And thank you very much all. See you inshallah soon in coming webinars and events. Thank you.
Finally, I want to thank two important persons, Professor Dr. Nabil for his excellent moderating and preparing all the scientific program for this, I think that informative webinar, and for Mr. Ala, my dear friend, my dear brother, and thank for Saudi General Hospital in general for this CME program, which give us a very informative data about different topics. Thank you.
Thank you. We'll close now.
شكرا يا فندم، شكرا ان انا كنت موجوده معاكم النهارده، وشرف لينا يا فندم ان احنا نبقى مع حضرتك دكتور نادر. يعني استفدنا كتير من حضرتك يعني، ومن كل الزملاء طبعا، دكتور حمزه، دكتور عامر، دكتوره اماني استاذتي وحبيبتي، دكتور نبيل طبعا استاذنا كلنا، وان شاء الله دايما نتقابل كده في الخير يا رب.
Just sorry, because the Dr. Amir, he is not, his video is off, but I can't forget Dr. Amir. Dr. Amir is one of the ID consultant eminent in Medina here. We learn from him a lot, and actually we have a very good coordination and cooperation. Thank you also for Dr. Amir.
Thank you all. Thank you, Dr. Hamza. You are our knight against COVID attacks. يعني أنت الفارس حقنا يا دكتور. Thank you, Dr. Amir. The presentation was more than great. Thank you a lot. We are honored to have you. Dr. Amani, inshallah we'll cooperate together inshallah soon to make a special webinar for pediatric endocrinology. دكتورة سهى، دكتور نبيل قال عنك ديزيرت، فعد ما في كلام بعد كده خلاص. Big thanks to my professor Dr. Nabil for moderating this webinar, and a very big thanks to Prof. نادر فصيح. يعني من أول مرة التقينا دكتور نادر، وحضرتك محب للرسول وللمدينة المنورة، وكنت مستعد تقدم أي شيء للمدينة وأهلها. جزاك الله خير على اللي قدمته لنا، وان شاء الله قريبا جدا نلتقي برحاب الحرم جنب الرسول ان شاء الله. جزاكم الله خير جميعا، ونفع الله بكم ان شاء الله.
الله يكرمك.
شكرا جزيلا.